Hopefully, if any of these would apply to you, you can use them. And I don't want you to think, as I'm talking, well, I could just do a whole exome sequencing and take care of this. That's a no-no. You've got to be able to do a physical examination, and still there's nothing faster, cheaper than a bedside diagnosis. So, and as you well are aware, maybe 30% of the patients, even more in some instances, who have multiple congenital anomalies will not have any definable defects in any of the testing we can do, including whole exome sequencing. So we still have a reason, a very good reason, to pay attention to the phenotypes that we see and be able to walk through them in an organized fashion. This secrets talk, I have a few assumptions that you don't recognize the phenotype initially or on any follow-ups for that matter. And that the phenotype is different from normal relatives. Obviously, if you have a phenotype where you have similarly affected relatives, that already tells you you've got a syndrome. And it makes it a lot easier, even when you don't make the diagnosis. You can sort of look at the older people and figure out the prognosis, the recurrence risk. So, except for prenatal diagnosis, it's pretty good, and sometimes it can help there. Now, this is something that may be foreign to some of you, and to others, like the old guy over there with the gray hair. We had to go through a lot of books and diagnostic programs looking for a differential, as well as our own files when we came across a phenotype that we didn't see. But not infrequently, we would find a match or a possible match that ultimately led to a diagnosis. And this assumes that all your testing that has been done is negative or has not yet been done. Here's a child with an unknown MCA, was a very small child at birth, so had intrauterine growth retardation, had a small head size, had malformed ears and short limbs. He was put through everything that I knew, and when I was seeing patients on a regular basis, about 1/3 of the patients I saw I could not clinically diagnose. So, and then the follow-up to those 1/3 of those patients was to go and research the phenotype, try to find the match. If there were any available testing that you thought was appropriate, to do that, and then to follow the individual up on a regular basis. And if there were any information out there that you thought you needed, to go find it. One of Hall's rules is that the most common reason for no diagnosis is not having all the available information. And the available information frequently is very simple and often very cheap. I never diagnosed this kid. I thought he might have one of the osteodysplasticus or MOPs, but he did not fit radiologically. The not so secret secrets, obviously careful documentation of the features. And this includes the phenotype at different ages, and then to pursue that as the child gets older, regular follow-up. Usually my unknown patients, if they were young, were seen every 6 months of the first couple of years. After that time, the phenotype doesn't change as rapidly, so it would stretch it out to once every year. And then by the time they got to be near adolescence, it was once every 4 to 5 years. With the caveat to the parents that if there have been any major changes in the child's well-being, any new testing that had been done, we would want to know about it, and we could change the frequency that we did the follow-up. I always review the photographs of the patient and family members. The cheapest test you can get is a photograph. Photographs of the family are extremely important, and they're very informative. You want to establish if the patient looks different from the family, or what features, normal features, in the family are coming through the syndrome, so you don't have to consider those features as part of the patient's syndrome. And once you've done all that and fudged in for age, you'll have a better idea of what you're looking at. And we already talked about reviewing books and anything you have access to. The thing about recognizing phenotype is to relook and relook and relook a lot. It's a few syndromes will imprint themselves in your mind's eye, and you won't have to continue to do that for that syndrome because it has some unique meaning to you or visualization to you. But for those that don't, looking at articles, looking at these books, going through differentials is something that may benefit you.
Dr. Paul, I had a question. When
Yes.
you talk about like if different features kind of add up from different family members, would you discount that? Because I have one family like that where the child looks completely different, but if you pull out each feature, you can match it up to some siblings and the parents.
No, that's what I was saying.
You would discount that?
I wouldn't discount that at all. And then there are what I call created syndromes, where the mother's abnormal, the father's abnormal, and the child looks like a combination of both of them. In other words, has the effects, phenotypic effects of two syndromes. If you don't see either one of those parents, or if you don't get a good feel for what their normal features or abnormal features are, you may give the child one syndrome diagnosis when there's actually two. And so you created, in your mind, you create a syndrome that's actually a combination, not specifically created. This is a child I saw a number of years ago who had a large anterior fontanelle, had an omphalocele, had a diaphragmatic hernia,
Sorry?
and had some renal issues.
Is it what?
And
Aspirin?
in looking through the books, also had agenesis of the corpus callosum.
Yeah.
So if you take all those features, agenesis of the corpus callosum, diaphragmatic hernia, omphalocele, that combination is almost unique. And so you knew, you could almost smell the diagnosis coming because of the uniqueness of the combination of features. And in fact, the same day, I was able to make a diagnosis of a disorder I had not only not seen before, but not heard of before. And it turned out to be
pause for a second?
the Donnai-Barrow syndrome, yes.
Reggie's gonna break you.
This patient I saw had a large anterior fontanelle, agenesis of the corpus callosum, omphalocele, and diaphragmatic hernia. It was also, I forgot to mention, deaf. And I'd never seen a child with this combination, and the combination was so unique that you knew you had a diagnosis if you could just find it. And with those features, you can find it. And the same day, I found this article, Donnai and Barrow reported this. You can see the large anterior fontanelle that's going down the forehead, the omphalocele, and this child had agenesis corpus callosum, and this is now a well-established syndrome. So sometimes the features are so unique that you know you're going to find a match quickly. Other times, and this is the worst situation you can be in, there are a number of subtle features. Don't get too frustrated because a large number of subtle features make a strong phenotype. A moderate amount and a small amount of subtle features, you don't know what to do with. And the phenotype may be very diffuse and not very comparable to what you're looking for in a diagnosis. This case was sent to me in 1992, I believe, by Dr. Martin in Chicago, who had this unique patient who had tibial agenesis, which is rare enough. But my goodness, look at this foot. This is 4 toes, and this is 2 extra toes, wide separation. This is a significant polydactyly, sometimes called mirror polydactyly. And then the upper extremity did not have any extra digits. Had hypoplastic digits with rounding of the tips and some missing digits. In addition, there was a narrow palpebral fissures, The face eventually turned out to be fairly specific for this disorder, but where I focused on was taking the unique feature of tibial aplasia and the extremely unique feature of both pre- and post-axial polydactyly, and was able to find a match. And here are two articles, the only two at the time with this condition. You can see the feet here. You can see the fingers are hypoplastic at the tips, but are bulbous. Again, a very unique group of features. And there was also, in our patient, hypoplasia, and both of these patients had genital abnormalities as well. So they're out there for the picking, and these are patients with unique features that allow for a fairly quick diagnosis clinically. We try to make a diagnosis so we can deal with the prognosis, counseling, which includes recurrence risk, and whatever interventions have been tried in the past, and we can evaluate those. The phenotypic diagnosis remains the cornerstone of the clinician's value to the patient, not just the dysmorphologist. His or her secrets translates into the art of dysmorphology, which we can all practice. And the more you practice, the more arty it is. They represent no more than an organized thought process with an excellent physical examination, and then some of the things that we'll talk about in just a few minutes. Imprinting the phenotype. Every patient that the examiner sees is imprinted in the examiner's mind. This gives us a diagnostic edge because once you've seen the patient, you don't have to remember the patient. It's there, it's free for the taking, and most of us can't remember that patient. And the more unique the patient is, phenotypically, the better, easier it is to remember. It is helped immensely by giving value to individual features, and we'll talk about that. And then sometimes how those features relate anatomically and embryologically to each other, and only occasionally by spontaneous gestalt. One of Hall's rules is gestalt is a dangerous way to diagnose patients. The one should not look at a patient and say, aha! You'll be right 90% of the time, and you'll be terribly wrong 10% of the time. And you won't remember that 90% of the time you're right. You'll remember that 10% of the time you're wrong. Each feature that is either newly recognized or was not previously present increases exponentially the opportunity to make a phenotypic match. These are called marker features, and they can be clinical or laboratory. This means that you see a patient once, twice, even 3 times or more. You have a phenotype, and then on the 4th time, there's been a change. Either you're smarter, or your visualization has focused on something you didn't see before, or the patient's changed, or there's a new laboratory test, non-diagnostic test, but some other test that gives you a clue that you're looking in the wrong direction and you need to think about looking at certain diagnostic possibilities. This is a good example. Here's a child, the same child by the way, who was born in Lexington, Kentucky at Central Baptist Hospital, and they thought the child had a storage disorder because he was very coarse, skin was thick, and I was asked to see him for the diagnosis. I agreed that he might have a metabolic problem, but the original screening, both clinical and radiological, did not support that. And so we decided just to follow him along. And I followed him for 4 different follow-up visits until this visit, when he was around 3 years of age. He looks much older than that. But what led us to the diagnosis was the development, which we weren't aware of and did not see the first 3 times, of acanthosis nigricans. And you can see the coarse, dark skin. This immediately made us think of a hyperinsulinemia situation, which you see in diabetics that are severe and poorly treated. And there's many other things here. The nipples are erectile, which is unusual. There is still no visceral maglate. Face remained coarse. And this child eventually, we diagnosed with Rabson-Mendenhall syndrome by going through the hyperinsulinemic malformation syndromes and ruling various ones out and ruling this one in. This is a rare syndrome. There's only about, I think now, 20 cases or thereabouts. It is very distinctive and it changes over time. Now, in previous lectures, I've shown you the face. I've shown you how I divide the face up, so I'm not going into this in any detail, but you should look at each of these areas for abnormalities. If you don't want to look at a regular human face, then you can make a drawing that fits all the major features. The thing this particular face does not show is how they integrate with each other. That's what makes the gestalt that a person has in their facial features. One thing I want to show you is how subtle things can be very useful. This is a normal boy, and I use him to show you that I divide the face into many different parts, but as far as the nose is concerned, there is three major parts to the nose. The lower 1/3, which is the fleshy part, the middle 1/3, which is the soft collagenous part, and the harder collagenous part, the upper 1/3. This is the way it should be, but in many syndromes it isn't, and this is a good example of a syndrome in which it isn't. You have in this patient with Lang syndrome, the lower 1/3 is present, there's no middle 1/3, but the upper 1/3 is present. And when the term that's frequently used for this is high set nose, but I don't particularly like that term, but it does infer that the distance from the filter here, or excuse me, from the upper lip to the columella of the nose is increased, and you can see that long distance. This phenotype of the Lang improves with age, but doesn't go away. There's many other features here that you can see. Whoops. You can see with the thin upper lip, of course, the hypertrichosis, and in this child, severe limb deficiencies. For lack of a better term, high set nose.
High set nose.
Primarily because people seem to be able to understand what that means. They don't usually understand how it became high set, or that there's a lot of other side effects like a long filter. Remembering the facial gestalt, remember I said we imprinted? Well, it's always easier to imprint when your patient looks like a famous person. Actor, criminal, whatever. And I'm going to show you some examples of that. You each have your own favorite characters, and so sometimes when you see patient, if you remember that by the famous patient or famous person, it's easier to keep that in your mind as you're seeing other patients. I'm going to show you a picture of Rubinstein-Tavy, Danny Thomas, the comedian who also started St. Jude's, and the Rubinstein-Tavy syndrome young lady, and we'll show you a patient with cutis laxa, which resembles Mr. Magoo of the cartoon character, and I'll show you one other individual that's also interesting. Here's a bona fide Rubinstein-Tavy child, and here's Danny Thomas. Primarily the nose is the major feature. It's a big nose, very high nasal bridge, and often the tip is peaked. This syndrome just reminds me of Danny Thomas, and that's the way. I don't need it to remember Rubinstein-Tavy because it's such a unique syndrome, but it's always interesting for people who haven't maybe seen one to see one and say, well, this looks like Danny Thomas. Some of you are young enough you don't know who Danny Thomas was. Sorry, that's Danny Thomas. Here's the guy who looks like Mr. Magoo with cutis laxa.
He was Marlo Thomas's father.
They may not know Marlo Thomas either.
Okay, but Marlo Thomas does not look like Rubinstein-Tavy. Either she's had a lot of work or her daddy's genes didn't come through. Here's Mr. Magoo from the cartoons with the squinty eyes and big cheeks. I don't need this to remember this, but just to show you that that's one of the ways to remember patients that you've seen in the past that you don't have a diagnosis for. And here's the Alfred E. Newman comic book character. And here's a patient that reminded me of Alfred E. Newman. I never have had a diagnosis of this boy at this point in time. And remember the outstanding facial features. The face is complex architecturally, but usually its gestalt is dominated by one feature, at least in your mind, one feature. And the examples would be the big lips in Coffin-Lowry, and we know that there's a number of syndromes of big lips. So we can use other features in Coffin-Lowry to help us, but to remember Coffin-Lowry as a possible diagnosis. And then the high arched eyebrows in Malfuch's syndrome. It has other unique features, which I'll tell you about, but it's something that if I think about high arched eyebrow syndromes, this is at the top of the list. Here I am with two brothers with Coffin-Lowry. They both have very large mouths and large lips. Usually the lower lip is everted. They often have wide-spaced eyes with some down slant, as this boy does. And then another very unique feature is the tapered fingers, which are found not only in the affected males, but also in many of the carrier females, without other features of Coffin-Lowry. And here's the Malfuch syndrome, in which you'd agree with me, these are high arched eyebrows, would you not? And but there's many other interesting features that I can remember the syndrome by, but the face is easier. There's usually a prominent coccyx that looks like a pseudo tail. They often will have fused radius and ulnar or radial humeral fusions, and a number of other features, including defects of their spine, clefting, for that matter. Remember the most common facial feature. We always think about the unique facial features, the rare ones. It's important to know those. But some syndromes have multiple facial features varying primarily with the percentage of their presence. And we tend to focus on the more obvious features. But it's important to pay close attention to the features that are the most common. And you'd like those most common features to be close to 100% frequency. My examples of that would be the bulbous nose in trisomy 13 and the malar hypoplasia, or slanted down cheekbones in Treacher Collins. Here are two patients with trisomy 13. You can see even with the cleft, the nose remains bulbous. There really isn't any other feature I know of in this condition that's 100% frequency. I've never seen a trisomy 13 without a bulbous nose. Here's a good example of a child without a cleft with a bulbous nose who has trisomy 13 and has, as an accompaniment, microphthalmia. So that when I tell people about this feature, even very experienced people, they often haven't noticed this particular feature as a high-frequency feature. Here's a collage of individuals with Treacher Collins. This boy obviously has a marked malar hypoplasia, which then causes the eyes to slant downward. And here you see a child with minimal slant, more slant, a grandparent with the slant, another slant, all due to malar hypoplasia. A child like this is not a diagnostic problem, but a child like this could be, and maybe this child wouldn't immediately raise the possibility of Treacher Collins. But on careful exam, particularly in young infants, you need to press down on the cheek fat, because the cheek fat will obscure the bony component of the face, and if you suspect a particular feature or are looking to rule it out, palpation sometimes is the best way to support or negate the feature. But we like to have the most unique facial feature be very specific. And they don't have to be the rarest feature. Sometimes they are, sometimes they aren't. Sometimes they can be subtle. Nasal tip crease in the midline defect syndromes is a good example of a very subtle but very unique feature. Or something more dramatic like a forehead or temporal cutis aplasia. We'll show you some examples of the nasal tip crease with frontonasal dysplasia in a patient with velocardiofacial syndrome. Something a lot of people don't recognize, but it's often confused with frontonasal dysplasia. It's entirely different. And then the forehead or temporal cutis aplasia that's found in Johansen's lizard and the Sedless syndromes, respectively. This is a patient with velocardiofacial syndrome with this tip of the nose with a crease. There's mild hypertelorism, and this patient did eventually come out to have velocardiofacial syndrome. There's about 5 cases in the literature with VCF with the nasal crease and the differential of frontonasal dysplasia. And then the lower pictures here are, this is the same patient, by the way, with Sedless syndrome. They have a lot of unique facial features. Early in the reporting of these syndromes, this syndrome specifically, it looked like the phenotype was always going to look very coarse, large lips, etc. And that hasn't been the case in long-term follow-up, and there's different genes for this now. But the temporal cutis aplasia was very unique, and using that as a search mode, if you've not seen this before, you would come up with this in a matter of minutes. The rarest feature is relative to its frequency among multiple anomaly syndromes or the general population. It can be almost pathognomonic. Here are some examples. Tongue hematoma in an OFD categorical diagnosis. Cutis verticus gyrata in Behr-Stevenson syndrome. Pedal dermal atrophy and dermal atrophy hypodysplasia syndrome. Hemifacial branchial defect, or hemangiomatous branchial defect in the branchiootofacial syndrome. Ear cyst and vascular dysplasia. I'm only going to show you photographs of the latter two. Here's a boy with branchiootofacial syndrome. When I first saw this child, even though he had a very unique face, the thing that immediately drew my attention was this reddish post-auricular streak. I thought it was hemangioma. Most people who had reported this syndrome originally thought it was a hemangioma also, but it's actually ectopic thymic tissue. Why, I don't know. And occasionally in this syndrome, this lesion can be also up in the hairline. You can see what I call is the triangular or pseudo-cleft, the V-shaped mouth. They have ocular features. A lot of things to make them unique, but nothing as unique as this. I keep pushing the wrong button. Here's a child with a skeletal dysplasia, diastrophic dysplasia, which means twisted dwarfism. And here you see the cysts that are present. In most of these cases, I say most because sometimes the cyst develops in utero and dissipates before the child's born. So you just have a little bit of an odd-looking ear, but not a cystic-looking ear. Those that don't have any major ear problems still can, within the first 2 months of life, develop cystic ears. Here's a feature that can be prenatal, congenital, or postnatal, and very, very unique. And then, I didn't include this in here, but the classic hitchhiker's thumb, because of the first metacarpal hypoplasia, is a major feature in this condition. So this is one of the few skeletal dysplasias you can actually book on to have the condition based on the physical examination. Prioritize features based on the frequency. Features have an individual value based on the frequency they appear in the general population. The rare features should be given more power in searching for the diagnosis. You can forget low-set ears as a useful feature. It's so common. VFD gets a 1+, but again, very common, not going to help you very much. Now we're starting to get into where the money is. Cleft lip, about a third of patients with cleft lip are going to have it on a syndrome basis. And when you add the other features in the patients you see with the cleft lip, it becomes very useful, and it has a 2+ value. Coimatresia, 1 in 10,000, 3+. This is how I recognize the charge association by looking at patients with cranial atresia and looking at their associated anomalies and putting the pattern together. Anophthalmia, frequency, very useful. Although most cases of anophthalmia are isolated, there are a number of syndromes that have an association with that. Tongue hamartoma brings you into the orofacial digital syndrome category, and very few other conditions have tongue hamartomas. Here's three different patients with charge syndrome or association. The corneal atresia, you can see this child has stents. One of the things that can be also useful is we know the ears are small and malformed, but in a small percentage of patients, they're missing the lower portion of the ear, and this is not found in many other conditions. I've seen it occasionally in infants and diabetic mothers. But most of the major features of the charge association are anomalies, not secondary effects. And the more true anomalies you have in a syndrome, the easier it is to make a diagnosis.
Dr. Paul, with charge, do the ears look similar to like DCF?
They can. I mean, the ears that are just small can look like almost anything. But the lower portions missing is very typical. But the most important thing is statistically, they're small. And then after that, you can find some idiosyncrasies. Here's the hamartomas in a child with orofacial digital syndrome and the postaxial polydactyly. Subtopic features. You sit here and you look at features that are not very useful. You say, well, what am I going to do with these? Well, maybe the feature you're looking at has a positional value or a degree value. That is particularly true for cleft lip, polydactyly, and short stature. When they are unusual in their location or their degree. If you take cleft lip, unilateral and bilateral, it's useful, as we've already discussed. But if you have a midline cleft, that's much more useful, much fewer syndromes to consider. Polydactyly, postaxial is very common. Can be useful as an additive feature. Preaxial, more rare, potential usefulness. And then central polydactyly, 4+, this is usually between the second and third digits of the hands and feet, much more useful. And the short stature by itself, 60 to 70% of chromosome disorders are short stature. So you don't want to fiddle around with short stature and put much emphasis on it. But if the patient is disproportionately short, not proportionally short like we just mentioned, but disproportionately short, the number of conditions is in the range of 2 to 300. And you think, wow, that's really more than I care to deal with. Add one more feature to that, and it goes way down, maybe to 20, 30 to 20. Add a third feature, and you're talking about a 1 in 5 chance that you'll be able to make a diagnosis. So disproportionate shortness is very important and useful. And then if you can take that disproportionate shortness and localize it to the part of the limb that is short, and this is particularly true for mesomelic, which is the middle part of the limb, the radial part and the tibial part, this becomes extremely useful. Here's a child with a very unusual physical feature who had hamartomas of the tongue, which I didn't show in this picture, but has central polydactyly. This little lump here is an extra hypoplastic digit. The central polydactyly goes along with the Bohr syndrome or facial digital syndrome too. And holoprosencephaly is a very useful feature, but it is useful, it is useful because it is central. Now you say, well, this is clearly a patient with holoprosencephaly. Look how close the eyes are set to the facial flatness. But a lot of holoprosencephaly patients don't have this degree of facial abnormality. And so you're looking for things like a midline cleft or notch or head, along with other features to suspect that there is a central nervous system anomaly. And then here's an individual with dyschondriosis. with a very short, low tibia. You can see the angulation here at the wrist. But it's the minor mesometal dysplasia, which is more often than not a compound of the dysconiosis patients, who has very short mesometal limbs. You can see that reflected in the X-ray. That gives you a diagnosis very quickly after you have the X-rays. You can't take the phenotype and know that her face is perfectly normal. You can't take the phenotype, but you need to get an X-ray of these limbs. Additive features. We talked about additive features, and some features are relatively common, like hereditary and obesity, so it doesn't make them particularly useful. But other features, such as polydactyly, are added to the differential. Are added. The differential is greatly reduced for your consideration. Primary feature: short stature, disproportion. Useful. We know we're cooking now. Let's add polydactyly. It doesn't make any difference whether it's post-axial, pre-axial, or central, although that would be of some help. And then this still won't make you a diagnosis unless there's some other features. And let's add multiple frenulum. And that makes the diagnosis Ehlers-Danlos, everything else being equal. And we'll show you the patient, I think it's next year with Ehlers-Danlos. They have conical teeth, tubular chest, post-axial polydactyly with male hypoplasia, and multiple frenulum. Here is a patient who has obesity. This can be additive as well as if you take obesity, and if it's extreme and congenital, that also adds power to the presence of obesity. But if it's a gradual obesity, it helps, but it doesn't make a diagnosis. They add an extra finger or toe, and it's a visual problems, and you're cooking with the possibility of Bardet-Biedl syndrome, this being retinitis pigmentosa. And here are 3 different individuals with Bardet-Biedl syndrome. Who are obese, did not start out obese, became obese fairly quickly. Morbid obesity in this syndrome is rare, but significant obesity is common. Look for extreme presentations. Many features are so common and non-specific they carry little or no value. However, if those features are extreme, they invariably lead to a diagnosis. I should have put invariably in quotes. If you take IUGR, it's very common in many of the syndromes we see, so by itself it doesn't have much. You add microcephaly to it, and then it becomes more useful, and then as an additive feature, in this situation it could be Nuloxova. They have very unique features, particularly involving puffiness of the hands and feet, that are very unique and extreme. If you just take microcephaly with IUGR, one of the common diagnoses of which there is at least 2, maybe 3, is the category of osteodysplastic dwarfism. Single atrium is a fairly uncommon cardiac defect. When you see it, you think about Ehlers-Danlos if there are other features, particularly if there's nail dysplasia or polydactyly or multiple frenulum. The Micrognathia fused ears is extreme and is not a diagnostic dilemma, but it's because it's extreme that it is diagnosable as a Gnathia cyanosia. Here is a child I thought had osteodysplastic congenital, but did not, and I've never been able to diagnose him. He's so unique. These unique patients will drive you crazy and stay with you for the rest of your diagnostic lives. So be willing to deal with that. Unusual combinations are another way of making diagnoses. Features that you just don't remember seeing the patient with those 2 features. And the further you get into this, looking at patients and knowing what syndrome features are, the better you'll be at figuring out when something just doesn't usually occur to you. Like double eyelashes and lymphedema. This is a dysmorphology lymphedema syndrome. And there's at least 2 genes for this now. This girl plucks her eyelashes, so you can't see the double row, but this is one of the few, if the only syndrome that has these two features. Now, the patient has other features, but they're not very contributory to the diagnosis. And then scalp defect, limb deficiencies. This used to be very unique, now called the Adams-Oliver syndrome. Hypoplastic fingers, often with missing nails, varying degrees of scalp agenesis. But there has been a number of cases reported now with either that or one or the other. So the variability is extreme. You have to have a high index of suspicion or something like this presentation. Pay close attention to symmetry and size. We are bilateral structures. We have 2 eyes, 2 hands, 2 feet, 2 nipples, a set of teeth on each side, and they should come close to being symmetrical, but they are usually mildly asymmetric, which tells you that in the abnormal situation, they can be fairly asymmetric and can raise the issue of various syndromes, some of which we'll discuss in just a minute. Here's a child with Klippel-Trenaunay syndrome who has hemangiomas of the leg and hypertrophy of that leg, posterior hemangiomas and macrocephaly. This could be one of the macrocephaly capillary hemangioma syndromes now, but this is a picture from about, I'd say, 30 years ago. So we didn't consider that in the differential. And here's another child with hemangiomas and asymmetry. I want you to note the hands here. This is a boy who came to me because of a possible congenital kidney problem. And he presented to his doctor with hematuria. And we looked at him, and he seemed to be a good-sized child. And his veins were more prominent than we normally expect to see. And by history, he was bigger than his siblings. And then we looked at his hands more closely. This is where the 5th finger should place relative to the 4th finger. Look at this one. The 5th finger is in the middle of the 4th fingernail. This is an overgrowth problem. We were questioning the hemangiomas because of the prominence of the veins in his hands and legs, but he actually had hemangiomas of his bladder. That's where he got his hematuria. And so that was eventually taken care of. But something as relatively subtle as this can give you an idea of an abnormality, in this case of a growth discrepancy. We see asymmetry of varying degrees with hemifacial microsomia or underdevelopment on one side of the face, including the ear. And then with Poland's anomaly, it's unilateral. The majority of patients with Poland's anomaly are not diagnosed in the nursery. The average age now, I think, is like 18 months to 2 years. It's usually the mother or father who recognizes it, not the physician. As the child gets older, the discrepancy of pectoralis major muscle, as you see here, forms this fairly dramatic crease. And frequently, these children will have a somewhat smaller hand and arm on that side, and on occasion they'll have syndactyly on the fingers as well. So, miscellaneous observations, we don't do this very much, but profile analysis can be useful. Looking at the patient from the side as opposed to the front. Facial changes with movement will pick up neurological problems as well as bony problems. Tics, mannerisms, and behaviors can become very useful, as you all know, particularly with Angelman syndrome and some of the other syndromes. Speech aberrations, unique lab abnormalities. Here's a patient with a mild degree of Costello syndrome. You can see the hair is thin. And on the lateral, the filtrum is fairly prominent, and the mandible a little bit small. I don't know that I could accurately, at this picture, make the diagnosis of Costello, but that's a fairly common profile picture. And here's a more extreme infantile onset or presentation. But Costello, you can see what I'm talking about, much more dramatic. Almost an instantaneous diagnosis just from the lateral. Here's an Angelman syndrome doing what she's supposed to do with the tuning fork, laughing, looking at the tuning fork. It's the only syndrome that does this. Here's a Rett syndrome, and you can see the normal response of a Rett is to cringe, look away, be fearful. And we've done this with autistic children, we've done this with normal children, and this is one of the few that will get a consistent laughing response. And they love the sound, they love to look toward it. It isn't frightening to them at all. So this is a cheap test if you want to apply. And we've got it down to at least the 6-month-old responding this way. Jacobson syndrome and TAR syndrome are two very interesting syndromes that this would be picked up fairly quickly because the degree of thrombocytopenia is fairly dramatic, and you can see bruising already in this young child. And of course, the radial defects would draw attention to this child. They have a prominent forehead, small mandible, and you can see this child's nose is fairly high set. He's got a little bit of a middle 1/3, does have a normal upper 1/3 and a lower 1/3. Jacobson syndrome is a little bit more difficult phenotypically, but thrombocytopenia is a common feature in this condition. It's usually not as severe, and they may not have bruising as you see in this condition. They are hypercaloric. They do have a small mouth. So in some cases you can make a phenotypic diagnosis or suspect it with the presence of thrombocytopenia, or in case it's not been recognized, order a test. Summary of secrets: no magic or shortcuts, except for whole exome sequencing. And remember, we still have 30% unknowns in that, using that technique. Exact observation and interpretation critical. Features can be tweaked, given value, manipulated to be more useful. Imprinting phenotypes is more of an innate need to know than a mind's eye. Pursuit, review, follow-up, keeping one's nose in the old and new literature maximizes the potential for diagnosis. And the changing phenotype should always be recognized. Give you some examples. This child was deaf on testing as a newborn, has very flat nose, has dystopia, was diagnosed with Wardenberg's. The mother brought him in, and we noted that she had a very prominent nasal tip, which is just the opposite of what her child has. But we and others are aware that this is the type of nasal tip that exists in affected adults with Wardenberg. So you go from a flat, blunt nose to a prominent nasal tip. This is the mother when she was in her 4 or 5 years of age, and you can see the same features that you see in her child. This is a condition involving mosaicism of 4P, and you can see what this child looked like at 3 years of age and what they look like at 13 and a half. I could not make that comparison. So you need to know syndromes at different ages and whether they vary or whether the features are static. And here's a mildly affected, apparently child with corneal blind who was not diagnosed. He was a little bit slow. And this child now is an adult, young adult, and you can see the features, and he had a note that knows how high set it is. Even his is a little bit high set. Maybe we could have been smarter from this photograph. But phenotypes change as they do. None of us look the same now as we used to, at least most of us. Some of us look better, most of us look worse. And here's the last slide, or next last slide, showing a boy who looks pretty normal here. A little bit of a prominent columella, nasal tip. But he had this unique, one, he had syndactyly of the second and third fingers. Two, he had syndactyly of the second, third, and fourth toes. He had this very large hallux. Sort of unusual here. Yeah. This particular group of patterning. This is called Filippi syndrome, and it was suspected based on these particular features. And Williams syndrome is just to let you know that they all don't look like elves. This is a little boy with pointed ear tips, as you might see here, in a true elf, or at least how elves are envisioned. But they do have large lips, eye-set nose, epicanthal folds, hair that's often unruly, and many other features, including very specific behavioral issues and voice. It's coarse. They always have what we call it sexy voice, a little coarseness, and that's present very early. Not conical teeth, but small pointed teeth. So every feature has some value. You can add them up, and it can be extremely valuable. And there's lots of tricks, and you can develop your own. And I think you'll enjoy looking at patients better. The best place to develop these skills is the mall. Go shopping, sit down in the center part and watch people walk by and make observations. I think that's it. Thank you. Yeah.
What's
Brian,
behind?
I find county fairs or festivals
Oh,
are
yes,
pretty good
yes.
places.
Yes. You're exactly right.
What's behind the unruly hair? Is it like